Hi, it's a great pleasure to be here with all of you. I really appreciate the opportunity. I wish it could be in person. I wish I had the opportunity to practice Spanish again with many colleagues in South and Central America and throughout the heart rhythm community. I had the pleasure to be assigned the topic how to assess risk for adverse outcomes in patients with ventricular tachycardia. These are relevant disclosures. I don't receive personal compensation, but all are institutional grants. No on-label or unapproved use will be disclosed in this discussion today. So this talk is founded upon a guideline statement that was a collaborative effort between the European Heart Rhythm Association, Latin American Heart Rhythm Society, Asian Pacific Heart Rhythm Society, and Heart Rhythm Society. I had the pleasure to serve as the Heart Rhythm Chair, and what we really wanted to do and set out to do was to provide a risk assessment in cardiac arrhythmias, what tools to use in the right outcome, really to give you a tool chest to approach patients, to improve outcomes, to kind of standardize treatment care, and also to really help identify risk of patients in unique populations. Now, the topic I have to speak on is quite broad, so I want to limit it to those that have defibrillators in place. As you can imagine, those are the patients with higher risk, in which risk profiles have been further established and identified, but more of the documentation and patients with other conditions that have less prevalence of adverse events can be found in the document. One of the challenges is in understanding risk is if we look at patients that without an ICD that should receive an ICD, 64 will be alive, 36 will be dead. We look at that same population, but consider patients that have an ICD. We can see we affect the outcomes in about 7 patients, but the vast majority of patients, those that didn't need the device were still alive. We made a small penetrance into those that ultimately died. So risk strategy and risk assessment is still critical. For lower risk patients, we need to improve screening. We need to understand the role of optimizing medical management. We need new studies of risk because although in this lower risk population, the ICDs don't necessarily have a benefit, these still account for the most incidences when you look in a population. So in a broad population, this is the patients that experience most of the adverse events. But the relative presentation is in this higher risk group. And so we need to find them, define them better, so we can really identify these 7 patients out of 100 patients that ultimately need an ICD, rather than implanting an ICD in 100 patients. We have to understand, again, how to optimize medical management. It's continually changing, and we know from European Society of Cardiology that new therapies have showed profound benefit in heart failure on top of current maximized guideline-based therapies. There's clearly a temporal risk that is unique both for ischemic and non-ischemic diseases. Are we applying the right treatment? Are we applying the right paradigms? What we do know with ICD shocks is they're significantly associated with mortality. In this group, there's a 20% increase in mortality over 4 years with just the presence of an ICD shock. And an ICD shock profoundly lowers quality of life outside in general, and outside of that, what it can do from a neurocognitive and neuropsychiatric standpoint. With ICD shocks, this is a distribution of shocks, and trying to understand, is it one shock or is there an accumulative effect of multiple ICD shocks? And what can be seen is compared to ATP only or no therapy, shocks in aggregate, in isolation, increase risk. In aggregate, and with more shocks, there's a heightened risk. So not only are they a marker of mortality, their ongoing presence identifies somebody at higher risk. This is a trial to look at the long-term follow-up of primary and secondary prevention cardioverter defibrillators. And what we can see is those patients, and this makes sense based on that prior study, that if you receive an ICD for secondary prevention, no matter what is done, including optimization of medical therapies, that your risk early on and over time of dying is higher. This is associated with the disease state that led to the ICD in the beginning. In ICD patients and those that had secondary versus primary prevention, shocks are associated with a higher rate of ICD shocks in general and recurrent ICD shocks, and those predict mortality. But what is interesting is even if you take the primary prevention group versus the secondary prevention group, there's a higher risk of inappropriate shocks in the primary prevention group compared to the secondary. And it may be that this group, there's a survival bias. It may be that more on antiarrhythmic drugs, but in these population-based studies, we can see this dichotomy of higher inappropriate shocks in those patients with primary prevention and higher appropriate shocks in those that have a secondary indication, with a pervasive mortality risk in those with secondary prevention and a pervasive mortality risk after ICD therapies for either appropriate or inappropriate shocks. So we'll go through the role of gender, and this is following the guideline statement. What is interesting is men compared to women, there's a lower risk of appropriate ICD shocks in women compared to men. And as you can see, it's shown in multiple studies, whether it's borderline significant or significant. The mortality risk, however, is similar between men and women. So although they're not receiving the same amount of shocks, women are dying at a higher rate outside of these, or a rate similar to men that's independent of shocks. And the ICD benefit among women, as anticipated then, is hard to measure. In fact, in most studies, ICDs, whether it's mixed population of scud heft, ischemic population of mated, non-ischemic indefinite, you can see that there was a trend in aggregation, but in these trials in isolation, women didn't receive a significant benefit, even though there was a perceived higher risk with ICD therapy. This is the Danish study, and this is well known that in a group of 556 patients with systolic heart failure and non-ischemic disease, there was no benefit seen over time with ICDs compared to control group, highlighting that ischemic patients have a higher risk at baseline. There was also no benefit in cardiovascular death, but there was a benefit, although event rates were very small for sudden cardiac death. And that makes sense as we're trying to isolate the population down to those exposed to significant ventricular arrhythmias. What is interesting with this study as well, and the most recent contemporary analysis, is when you look at gender, we see the same variance, with men tending to benefit from their ICD, men receiving more ICD shocks, and women showing no benefit. In fact, completely no compared to control alone. So male gender is identified by our document as a high-risk marker to consider. The next we discussed was atrial fibrillation. We know that a history of atrial fibrillation is associated with a higher risk of heart failure hospitalization and ICD shocks compared to patients without a history, and also a higher risk of heart failure hospitalization. And incident AFib augments all of these risks of death, heart failure hospitalization, and ICD shock. This was a study from the randomized prospective intrinsic RV study that we wrote up. There's numerous other studies that have shown the role of atrial fibrillation as a marker of death, heart failure hospitalization, worsening cardiomyopathy, and ICD shocks. So this trial from Brian Powell, using the massive data set that is the altitude data set with Boston Scientific, trying to understand what shocks mean and do they have equal significance. So these are 3,800 patients that had an initial ICD shock, and they separated them based upon the arrhythmia that resulted in the shock or if there was EMI. And you can see there's 15% had VF or polymorphic VT, 35% monomorphic VT, and then about 20% were shocked for SVT or atrial fibrillation and flutter. And at this time, there was a question, is it the ICD shock alone that is moribund, or is it the arrhythmia that drives the ICD shock that contributes to the most significant risk? And in this study, those patients that had VF, their survival rates were much lower compared to atrial flutter, and those rates were much low. That mortality rate was much higher than those at sinus tachycardia or EMI sensing. So showing that, in fact, the arrhythmia that results in the ICD shock, as mentioned before, atrial fibrillation, as mentioned before, ventricular arrhythmias, are significant predictive findings of recurrent ventricular arrhythmias and mortality in patients with ICDs. Less so when the therapy was related to something that, such as noise, that is independent of the heart condition itself. So what about patient-level predictors and just looking at the patient and understanding risk? We identified a few in the document. Clearly, aging is one. As we get older, the risk of having appropriate ICD therapies goes up. We talked about our male gender, when you get aging significantly, it goes down. Early, it goes up. Non-sustained VT, atrial fibrillation, all of these things predict risk. If patients have exposure to frequent RV pacing, or on digoxin, or have renal failure, these are patient-level predictors of risk. Highlighted in the document was aging to a certain point, of course, male gender, secondary cardiac events, atrial fibrillation, and we actually identified diabetes as well. And you can see diabetes here, increased risk of death, not so much ICD therapies, but death as a risk factor of mortality. In weighing the evidence of these, we have on the right the relative weight. And when you start to categorize patients not by a single risk factor but by multiple, you can significantly predict the likelihood of shocks going up from 1% up to 10% if you're in the highest risk group with a score of 9 to 10 compared to 1. But again, this is comprised of all of these significant risk factors, and many of which were identified in the document. So what about biomarkers? And this was an area of controversy and a lot of discussion by our consensus committee. And one of the reasons you may not see certain biomarkers if they weren't applied in a prospective design for the indication that the risk score was developed. For example, CHAD score was developed to predict thromboembolism, but not developed necessarily to predict mortality. And so so if it was used appropriately and showed value, it got a higher recommendation. We highlighted a few, in particular pro-BNP. You can see as this goes up, there's a significant predictive value of ventricular arrhythmias. Troponin, which is well studied within cardiomyopathy populations, is prognostic of mortality and worsening cardiomyopathy in a somewhat dose-dependent way, increases risk. So does IL-6 and CRP. And you can see some variants in other biomarkers that were studied. Similar to the prior data set, there is value in combination of risk factors. And if you receive a score of 15 to 20 compared to 5 to 9, you can see a significantly lower risk of mortality with biomarkers alone. And that can be done as well, looking for ICD shocks, showing a 10 to 15% risk. You can take the same data, and here's the odds ratios for all of the biomarkers studied. The one being the highest was troponin T, highly sensitive troponin T, but pro-BNP1 that we identified as well, showing that these also strongly predict mortality. This gives you the distribution of elevation. Most patients had 2 to 3 elevated, and as you get multiple, and you can predict mortality along with appropriate ICD therapies. It's important to recognize when we consider cardiomyopathy and prediction of it that there is a correlation between ejection fraction and mode of death. As the ejection fraction decreases, the relative contribution of arrhythmic and cardiac arrest deaths tends to plateau, while mortality rates go up, highlighting the transition of a mode of death from sudden arrhythmogenic to pump failure death. And so some of these things can be very predictive in patients with moderate dysfunction and can be less so with severe dysfunction. Those to predict ICD therapies and meaningful survival, but those in these range often predict total mortality, as again, they reflect the degree of cardiomyopathy and risk not only of arrhythmia, but of pump failure. So what about inappropriate shocks? I have a little bit of time. I want to finish up in this area. There's also data to highlight risk of inappropriate shock. And this is a population of patients, 1,500 patients. The average population very similar to other ICD trials, and some of which were on antiarrhythmic drug therapy, about 3/4 of the patients with a prior history of atrial fibrillation and 23%. And the risk of inappropriate ICD shocks in this population was about 20%, similar to what we saw on the altitude remote monitoring data set. One of the strongest predictors of is the presence of an inappropriate shock to receive a second one. In fact, if you have one inappropriate shock over 5 years, there's a 60% chance or 2/3 risk chance that you'll have another ICD shock. And so the presence of this shock is very predictive of the second. When we look at multivariate predictors of risk from this table here, aging associated with risk, not as much so with appropriate shocks, as that's driven by an augmentation of mortality plus ICD shocks and atrial fibrillation as anticipated, as this tracks very closely with risk of appropriate shock. And again, the most important part is an appropriate shock increased it by 60%. And all of the things we discussed previously that highlight the risk of appropriate shock now interplay with the risk of inappropriate shock. So a 60% chance if you had an appropriate shock to receive a second inappropriate shock, and atrial fibrillation doubling the chance of receiving an inappropriate shock therapy. So with inappropriate shock therapies, it is critical that our management plays a role, as well known, and this is the MADE at RIT trial, showing that the way we program the device can significantly lower the risk of inappropriate shocks. Where in an era of conventional therapy with early ATP and to lower risk of stroke and engaging the heart earlier actually led to a 30% chance of an inappropriate shock. By changing that to a high zone, one zone only, and delaying the time of therapy, you can significantly lower the risk of appropriate shocks, but inappropriate shocks over time as well. And finally, if we add SVT discrimination algorithms, we can also lower the risk of inappropriate shocks. And the study from Ken Ellenbogen and his group showed that if we place the discriminators, put the discriminators on at the time of device programming, here in blue, the risk of inappropriate shocks was 4%. If we had the discriminators on in the VF zone only, so in a one zone only, again 3.3, and these were similar over time. But if the discriminators were off, the risk of inappropriate shocks were 22, so almost increasing this 7 to 8%. And if the discriminators were off in the VF zone only, so only rapid, there was also an increased risk of inappropriate shock. So SVT discriminators are critical to lower risk of inappropriate shock, and when used appropriately, they don't impact the risk of device therapies or resuscitation for appropriate shock therapies. So in conclusion, ICD shocks, both appropriate and inappropriate, strongly associate with an increased risk of mortality and a lower quality of life. Inappropriate ICD shock mortality risk is driven primarily by atrial fibrillation. But all ICD therapies, whether appropriate or not, lower long-term quality of life. Ventricular arrhythmias, age, AF, male gender, heart failure severity predict risk of appropriate ICD shocks. And biomarkers are predictive alone in combination, but biomarkers have not necessarily, from an upfront standpoint, been used in a design trial to understand their use in a prospective manner to identify patients at risk and perhaps alter treatment. And prior appropriate shocks, age, AF, and ICD programming strategy predict inappropriate shocks. And again, these inappropriate shocks have an impact on long-term adverse events when they're for atrial fibrillation. So I hope you enjoyed this and you enjoyed the consensus document. It was a pleasure of ours to do it and with wonderful colleagues around the world. And again, this is just a small segment of the risk relationship in those with moderate to severe cardiomyopathy that require an ICD, but many of these same attributes and risk rules trend towards risk also in healthier hearts. Thank you very much.